Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
Hello again from Axxess headquarters here in Dallas. My name's Jennifer Gibson Osborne. I am the Senior Clinical Consultant here at Axxess, and we are working today on OASIS-D Accuracy webinar series. This is part 4 of 4. We're going to go over the last few items that are new to the OASIS-D data set and learn item-specific guidance in this particular session. We're glad you joined us and hope that you enjoy learning with us. As a little housekeeping, please note that the slides that you have privy to, if you print these out and use them, just remember that at the time of this recording, the information is correct, but not everything that I say will be in the slides when you receive them. So just pay attention to the fact that this might be later on when you're referring back and something might have changed through the OASIS-D quarterly Q&A, or you might not remember exactly how I said something, and when you look at the slide, you might interpret it differently if you're like me. That's what I tend to do when I go to seminars and look back. But anyway, just make sure that you remember that, okay? The objectives of this 4-part seminar series have been to understand official OASIS-D guidelines and conventions, to learn the new and modified OASIS-D items, to understand the OASIS-D implications in quality, payment, and outcomes measurement, to learn clinical tips for obtaining accurate OASIS-D data, and then apply item-specific guidelines and guidance to scenarios as we go through. And that's what we're going to do in this session. Particularly in session 4, we're going to look at GG0170, which is the mobility question, J1800 that asks if the patient has had any falls, and then J1900, the number of falls the patient has had. Let's get started by looking at the item itself. Now, as I said in part 3, if you don't already have a printed copy of the new GG and J items in front of you, I would pause the presentation and run and get a copy of that, or pull it up on a different monitor from the OASIS-D guidance manual. Unfortunately, these items are so long that they wouldn't fit on a PowerPoint presentation all together so that you could read them, or I could even read them. So because of that reason, they're broken into different sections in the slides, and as we're looking at scenarios or you're learning, you might want to see it as a whole on a one-pager. So for that reason, I would encourage you to have a copy of the actual item in front of you in addition to the PowerPoint presentation. Now for GG0170, we're looking at the patient's mobility, and I want you to note, as we did in the prior session, that you have different versions of the question depending on which timeline you're assessing. For the start of care, resumption of care, you're going to have different items being asked than you would at follow-up and then at discharge. Now, for this particular item, we're coding the patient's usual performance at start of care, resumption of care for each activity using the 6-point scale, which is what we see here on the screen. That 6-point scale is a 6, 5, 4, 3, 2, 1, and it functions exactly the same as the G130 that we just learned in session 3. If the activity was not attempted at start of care or resumption of care, we code the reason why it was not, and then we're also coding the patient's discharge goal using a 6-point scale. The use of code 7, 9, 10, or 8, 8 is permissible to code discharge goals. So again, just looking at that 6-point scale, you've got a number 6 is the patient is independent, a number 5, there's setup or cleanup assistance only, number 4, supervision or touching assistance only, number 3 is partial moderate assistance, number 2 is substantial or maximal assistance, and number 1 is dependent. If we didn't attempt the activity for some reason, we would code the reason why, and those reasons are either number 7, patient refused, and number 9, it was not applicable because the patient didn't perform this activity prior to the current illness, exacerbation, or injury. And number 10, it was not attempted due to environmental limitations like a lack of equipment or weather constraints. Or 8.8 was not attempted due to medical conditions or safety concerns. So all of those items are exactly like they were in the GG130 item that we went over in session 3. Now what we're looking at particularly, again, for start of care, resumption of care, In the left-hand column, we're looking at the patient's performance on start of care, resumption of care. Again, their usual performance while we're in the home and 24 hours just prior. The right-hand column then is the discharge goal, and that is where we're trying to anticipate by discharge, whenever we anticipate that discharge will happen, what the patient's ability will be at that point. All right, so let's look at the different rows. A, we're looking at rolling left to right. We're looking at the patient's ability to roll from lying on the back to the left and then the right side, and then return to lying on the back on the bed. In row B, we see sit to lying is to be assessed. We're looking at the patient's ability to move from sitting on the side of bed to lying flat on the bed. C is lying to sitting on side of the bed. This is the ability to move from lying on the back to sitting on the side of the bed with feet flat on the floor and with no back support. D is sit to stand. This is the patient's ability to come to a standing position from sitting in a chair, wheelchair, or on the side of the bed. We also have a row E, chair, bed to chair transfer. This is the patient's ability to transfer to and from a bed to a chair or wheelchair. So to and from, so getting out of bed to the chair or the wheelchair and then back in bed. Not just part of that, all of that. Row F is toilet transfer. This is the patient's ability to get on and off a toilet or commode. G, these are some new ones for us RNs, and the therapist usually assess these things very well, by the way. Just as sidebar, I would, even if this were my agency, have my best physical therapist and occupational therapist work with the clinicians team on assessing these items properly, because they do that. They do that all the time. We as RNs don't do that very much. So you might have your therapist do an in-service on how to properly assess these items. And as a trade, we'll teach them how to do drug regimen reviews, right? I say that jokingly, of course. We know that they're capable, but we know that not all agencies do that. So maybe we could just trade out. Anyway, row G, your car transfer. This is the patient's ability to transfer in and out of a car or a van on the passenger side. This does not include the ability to open or close the door or fasten the seatbelt. Now, you may be asking, why on earth do they want to know that for home health? Well, we need to see if the patient can get to other care settings to get health care if they need it, right? And what is their ability to get there? This can also help us to determine homebound status and to justify homebound status if need be. All right. Row I, walking 10 feet. We are assessing the patient's ability once standing to walk at least 10 feet in a room or a corridor or a similar space. All right. At J, we see walking 50 feet with 2 turns. Once standing, we're looking at the patient's ability to walk 50 feet and make 2 turns. At K, this one is one of my favorites and gets the most publicity whenever I'm teaching, okay? K is walking 150 feet. Once standing, the ability to walk at least 150 feet in a corridor or similar space. Now, just for those of you who are not therapists and you're trying to wrap your brain around 150 feet, I had to look this up because I wasn't real sure how far that was. Did you know on a Major League Baseball field, from home plate to first plate is 90 feet. So if you're thinking about how far this is, 90 feet, wow, that's only about halfway around. 150 feet, we're talking about they're almost rounding second base, right? So first of all, most of our clients probably don't have rooms or corridors that long. And then if you're not really sure about and you don't know about a Major League Baseball field, we're pretty good at determining room sizes. You know, most rooms are 10 by 10 or 14 by 16 or whatever. So that will give you a bit of a measure of how far this actually is. And it can be an issue for both environmental reasons, patient safety, and health considerations. They may not be able to manage that. So we're going to talk about that a little bit more in just a bit. Row L is walking 10 feet on uneven surfaces. This is the patient's ability to walk 10 feet on uneven or sloping surfaces, indoor or outdoor, such as turf or gravel. And row M, we see one step or a curb. This is the ability to go up and down a curb and or up and down the step. N is 4 steps. This is the patient's ability to go up and down 4 steps with or without a rail. O is 12 steps, the ability to go up and down 12 steps with or without a rail. P is picking up an object. This is the patient's ability to bend or stoop from a standing position to pick up a small object such as a spoon from the floor. Now you'll notice, by the way, on row M and N, if at start of care we code those as 7, 9, 10, or 8, 8, it skips down to picking up the objects, right? Most of your electronic health records will go ahead and automatically do the skip pattern for you depending on your answer. Then we get into Q, R, and S. If we've made it that far, it's asking, does the patient use a wheelchair and or a scooter? If the answer is no, you skip and go on to GG, the next question. If it's yes, you keep going. So does the patient use a wheelchair and or scooter? If so, R, can they wheel 50 feet with 2 turns? Once seated in the wheelchair or scooter, the ability to wheel at least 50 feet and make 2 turns. We're answering in the left side what they're actually able to do at start of care or resumption of care. In the right column, we're answering the discharge goal. And if they actually have a wheelchair or scooter at RR1, we are to indicate if this is a manual wheelchair or a motorized wheelchair or scooter. And finally, in row S, we are looking at the patient's ability to wheel 150 feet. Once seated in a wheelchair or scooter, the patient's ability to wheel at least 150 feet in a corridor or similar space. And if they are doing that, we're looking to see whether or not they're using a manual or motorized wheelchair. Now, that's the start of care, resumption of care version. At follow-up, you still have the 6-point scale. You still have your activity not attempted codes, but your performance follow-up, you're only looking at rolling left and right, sitting to lying, lying to sitting on side of bed, sit to stand, chair bed transfer, toilet transfer, walking 10 feet, walking 50 feet, walking 10 feet on uneven surfaces, 1 step, 4 steps, and wheeling 50 feet with 2 turns. However, at discharge, you're looking at all the activities again. A is rolling left and right. B is sitting to lying. C is lying to sitting on side of bed. D is sit to stand. You're looking at chair bed to chair transfer, toilet transfer, car transfer, walking 10, 50, and 150 feet respectively, walking 10 feet on uneven surfaces, doing 1 step, 4 step, 12 steps, picking up an object, wheeling 50 feet with 2 turns, or wheeling 150 feet. If all of those apply, we are to test all of those. Let's get into some item guidance for this particular GG0170 item. According to our OASIS-D guidance manual, Chapter 3, GG0170 identifies the patient's ability to perform the listed mobility activities and the discharge goals. Licensed clinicians can assess the patient's performance based on direct observation, which is preferred, as well as reports from patients, clinicians, care staff, and/or family. When possible, again, CMS invites a multidisciplinary approach to patient assessment. Patients should be allowed to perform activities as independently as possible as long as they are safe. If helper assistance is required because the patient's performance is unsafe or of poor quality, score according to the amount of assistance provided. It shows us that activities can be completed with or without assistive devices, and the use of the assistive device to complete an activity should not affect coding of the activity. Patients with cognitive impairments and limitations may need physical assistance and/or verbal assistance when completing the activities. Code based on their need for assistance to complete an activity safely. We're also coding the patient's functional status based on a functional assessment that occurs at or soon after the patient's start of care, resumption of care. The start of care, resumption of care function scores are to reflect the patient's baseline and are to be based on observation of activities to the extent possible. When possible, the assessment should occur prior to the start of therapy services to capture the patient's true baseline status. This is because therapy interventions can affect the patient's functional status. A patient's functional ability can be impacted by the environment or situations encountered in the home. Observing the patient in different locations and circumstances within the home is important for a comprehensive understanding of the patient's functional status. If the patient's ability varies during the assessment time frame, record their usual ability to perform each activity. Do not record the patient's best performance and do not record their worst performance, but rather the patient's usual performance, which is true greater than 50% of the assessment time frame. For the Home Health Quality Reporting Program, HHQRP, a minimum of one self-care or mobility discharge goal must be coded. However, agencies may choose to complete more than one self-care or mobility discharge goal. Code the patient's discharge goals using a 6-point scale. Use of the activity not attempted codes, which are the 7, 9, 10, or 8/8s, is permissible to code discharge goals. Use of a dash is permissible for any remaining self-care or mobility goals that were not coded. Now, discharge goals can still be coded the same as start or resumption performance. They might be higher than or they might be lower than your start resumption performance. And we're going to get into that in the examples. If the start of care, resumption of care performance of an activity was coded using one of the activity not attempted codes, a discharge goal may be submitted using a 6-point scale if the patient's expected to be able to perform that activity by discharge. Now, licensed clinicians can establish the discharge goal at the time of start of care or resumption of care based on their prior medical condition, the assessment that we have at that visit, the self-care and mobility status, discussions with the patient and the family, our professional judgment, the profession's practice standards, expected treatments, patient's motivation to improve, anticipated length of stay, and the discharge plan. Remember, goals should be established as part of that patient's care plan. And as we said in session 3, what that's really talking about is your goals here should match what's on your care plan for this patient. At discharge and follow-up, the clinician should code the patient's functional status based on a functional assessment that occurs within the assessment time frame. The discharge time period under consideration on discharge includes the last 5 days of care. This includes the date of the discharge visit plus the 4 preceding calendar days. Code the patient's functional status based on a functional assessment that occurs at or close to the time of discharge. Next few slides you're going to see again where we talk about what each code in the 6-point scale means. Independent means the patient completes the activity by him or herself with no assistance from a helper. Number 5, set up or clean up assistance means the helper sets up or cleans up and then the patient can complete the activity after that. The helper only assists prior to or following the activity but not during the activity. For example, the patient might require placement of a bed rail to facilitate rolling, or they require setup of a leg lifter or other assistive devices, and once they have that, they can manage the activity. Number 4, supervision and or touching assistance. If the helper provides verbal cues and or touching, steadying, and or contact guard assistance as patient completes the activity. Assistance might be provided throughout the whole activity or intermittently. For example, if the patient requires verbal cueing, coaxing, or general supervision for safety to complete the activity, or the patient might require only incidental help like contact guard or steadying assistance during the activity. Code number 3, partial moderate assistance, means the helper does less than half the effort. The helper would hold or lift or support trunk or limbs, but they provide less than half the effort. For example, the patient might require assistance like partial weight-bearing assistance, but again, that helper's only doing less than half the effort here. And number 2, substantial maximal assistance is appropriate if the helper does more than half. For example, the helper might lift or hold trunk or limbs and provides more than half the effort. Code number 1, dependent, means the helper does all the effort. The patient does none of the effort to complete the activity, or in order to complete the activity, they need 2 or more helpers for the patient to complete the activity at all. All right, code number 7, patient refused. If the patient refused to complete the activity would be the proper code. Code number 9, non-applicable, means the patient did not attempt to perform this activity and they didn't perform this activity prior to the current illness, exacerbation, or injury. Number 10, not attempted due to environmental limitations. If the patient did not attempt this activity due to environmental limitations like lack of equipment, weather constraints, You know, if it's snowy and icy and you're supposed to go out and test them on unlevel surfaces or curbs, and that's not going to be safe for the patient, that would be a number 10. Code number 88, not attempted due to medical condition or safety concerns. That's the correct answer if the activity was not attempted due to medical condition or safety concerns. Patient's out of breath, they can't manage to walk 150 feet without, getting lightheaded or whatever's going on. Whatever that might be, that would be a proper answer. And then last, a dash is a valid response for this item, although CMS expects dash use to be a rare occurrence. All right, on follow-up and discharge performance, if a patient does not attempt the activity and the helper does not complete the activity and the patient's usual status cannot be determined based on patient or caregiver report, then you're going to code the 7, 10, 9, or 88 appropriately. If the only help a patient needs to complete an activity is for a helper to retrieve an assistive device or an adaptive equipment like a cane for walking or a tub bench for bathing, then number 5, setup or cleanup assistance would be appropriate. Don't forget, if 2 or more helpers are required to assist that patient to complete the activity, that's going to be a number 1 dependent. And if you use a dash, you're indicating no information. Don't use a dash if the reason the item was not assessed was because the patient refused, or it wasn't applicable, or it wasn't attempted due to environmental limitations, or the activity was not attempted due to a medical condition. Let's get back into the rows on this question and look at what each item is specifically assessing as we go through the rows. So at 170A, this is the roll left and right. We're looking at follow-up and discharge. This includes the patient rolling to both the left and the right while in a lying position. If at the time of assessment the patient is unable to lie flat due to a medical condition or restriction, but they could perform this activity prior to the current illness, exacerbation, or injury, you would code an 88, not attempted due to medical condition or safety concerns. For example, if a clinician determines that the patient's new medical need requires that the patient sit in an upright sitting position rather than a slightly elevated position, then GG0170A would be 88, not attempted due to medical condition or safety concerns. If at the time of the assessment the patient is unable to lie flat due to medical conditions or restrictions and they couldn't perform that activity prior to the current illness, exacerbation, or injury, code a number 9, not applicable. For GG0170A, roll left and right, clinical judgment should be used to determine what is considered a lying position for the patient. For example, a clinician could determine that a patient's preferred slightly elevated resting position is lying for that patient. Let's do some practice scenarios with 170A. This is your roll left and right. This is going to be at start of care. At start of care, the physical therapist helps Mr. R turn on his right side by instructing him to bend his left leg and roll to the right side. He then instructs him how to position his limbs to return to lying on his back, and then repeat a similar process for rolling onto his left side and then return to lying on his back. Mr. R completes the activity without physical assistance from a helper. Mr. R was moving about in bed without difficulty prior to the hospitalization. The therapist expects Mr. R will roll right and left by himself at discharge. So how would we answer GG0170A1 and A2? GG0170A, roll left and right, start of care performance would be 4, supervision or touching assistance. The discharge goal would be a 6, independent. At start of care, the PT provides verbal cues or instructions to Mr. R as he rolls from his back to his right side and returns to lying on the back. The PT does not provide any physical assistance. After assessment and considering the current condition, the therapist expects he will be independently rolling left and right at discharge. Okay, let's go on to sit to lying. This activity in row GG0170B includes the ability to move from sitting on the side of the bed to lying flat on the bed. If at the time of the assessment the patient's unable to lie flat due to medical conditions or restrictions, but could perform this activity prior to current illness, exacerbation, or injury, then you would code 88, not attempted due to medical condition or safety. For example, if a clinician determines that a new patient medical need requires that the patient sit in an upright sitting position rather than a slightly elevated position, then you're going to code GG0170B Sit to Lying as 88, not attempted due to medical or safety concerns. If at the time of the assessment the patient's unable to lie due to medical conditions or restrictions and couldn't perform that activity prior to the current illness, then you would code a 9, non-applicable. For GG0170B Sit to Lying, clinical judgment should be used to determine what is lying position for the patient. For example, the clinician could determine that a patient's preferred slightly elevated resting position is the lying position for that patient. So let's put that in a scenario. GG0170B, Mr. A suffered multiple vertebral fractures due to a fall off a ladder. At start of care, he requires assistance from a therapist to get from a sitting position to lying flat on the bed because of significant pain in his lower back. The therapist supports his trunk and lifts both legs to assist Mr. A from sitting on the side of the bed to lying flat on the bed. Mr. A assists himself a small amount by raising one leg on the bed and then bending both knees while transitioning into a lying position. How would you answer GG0170B1? GG0170B1 Sit to Lying start of care performance would be coded 02 Substantial Maximal Assistance. The therapist provided more than half of the effort for the patient to complete the activity of sit to lying. Let's do another scenario for GG0170B, Sit to Lying. At start of care, Mrs. H requires assistance from two helpers to transfer from sitting at the edge of the bed to lying flat on the bed due to paralysis on the right side, obesity, and cognitive limitations. One of the helpers explains to Mrs. H each step of the sitting to lying activity. Mrs. H is then fully assisted to get from sitting to a lying position on the bed. Mrs. H makes no attempt to assist when asked to perform the incremental steps of the activity. How would you answer GG0170B1? That would be a 1 dependent because the patient does none of the effort to complete the activity and the assistance of two helpers is needed to complete the activity of sit to lying. If two or more helpers are required, then it's coded as a 1 dependent. All right, let's look at the next row, GG0170C. This is lying to sitting on side of the bed. This activity includes patient transitions from lying on his or her back to sitting on the side of the bed with feet flat on the floor and sitting upright on the bed without back support. If the patient's feet do not reach the floor upon lying to sitting, the clinician will determine if a bed height adjustment, like a stool, would be required to accommodate foot placement on the floor or the footstool. Back support refers to an object or a person providing support of the patient's back. If at the time of the assessment the patient is unable to lie flat due to medical conditions or restrictions, but they could perform this activity prior to current illness, exacerbation, or injury, you code 88, not attempted due to medical condition or safety. However, if the clinician determines that a new patient medical need requires that they sit in an upright position rather than a slightly elevated position, then code GG0170C lying or sitting on the side of the bed as an 88 as well. If at the time of the assessment the patient's unable to lie flat due to medical conditions or restrictions and could not perform the activity prior to the current illness, exacerbation, or injury, you would code a number 9, not applicable. For GG0170C, lying to sitting on the side of the bed, clinical judgment should be used to determine what's considered lying for this patient. For example, a clinician could determine that the patient's preferred slightly elevated resting position is lying for that patient. So let's look at 170C scenario. Mrs. H is recovering from a spinal fusion. At start of care, she rolls to her right side and pushes herself up from the bed to get from a lying to seated position. The therapist provides needed verbal cues to guide Mrs. H as she safely uses her hands and arms to support her trunk and avoid twisting as she raises herself from the bed. Mrs. H then safely maneuvers to the edge of the bed, finally lowering her feet to complete the activity without hands-on assistance. How would you score GG0170C1? That would be a 4, supervision or touching only, because the therapist provides verbal cues only as Mrs. H safely moves from a lying to sitting position on the side of the bed with her feet on the floor. Let's do another. Mr. B is being admitted to home health for pressure ulcer care. He has complete tetraplegia from an injury a year ago and has been unable to bear weight and standing since the injury. At start of care, using a patient lift that does not require him to come to standing, he's transferred from his bed into a wheelchair with assistance. How would you code GG0170D1? That start of care performance would be coded in number 9, not applicable. This activity was not attempted at admission, and the patient did not perform this activity prior to the current illness, exacerbation, or injury, which is the pressure ulcer, due to the diagnosis of complete tetraplegia. The next row is GG0170E. This is chair, bed-to-chair transfer. This activity begins with the patient sitting, either in a chair or a wheelchair or at the edge of the bed, and then transferring to sitting in a chair, wheelchair, or edge of the bed. Now, sit to lying and lying to sitting are not assessed as part of GG0170E, and if a mechanical lift is used to assist in transferring a patient for a chair, bed-to-chair transfer, and 2 helpers are needed, what would that be? That would still be a number 1 dependent, even if the 2 people are using a mechanical lift. Even if that patient assists with all or part of the chair, bed-to-chair transfer. All right, so let's do an example. Mr. L had a stroke and uses a wheelchair for mobility. When Mr. L gets out of bed at start of care, the therapist moves the wheelchair into the correct position and locks the brakes so that Mr. L can transfer into the wheelchair safely. Mr. L transfers into the wheelchair by himself without the need for supervision or assistance during the transfer. The family reports that Mr. L does transfer safely without the need for supervision once that wheelchair is placed and locked. The nurse does not expect Mr. L's mobility status to change by discharge. So how would we code GG0170E1 and E2? 170E1 would be coded a 5 at start of care, setup or cleanup assistance only, and it would also be a number 5 at discharge because the helper must provide setup assistance by setting up the wheelchair and locking it. Once setup is provided, Mr. L transfers safely and doesn't need supervision or physical assistance during the transfer, and we expect that he's going to continue to need wheelchair setup assistance for this transfer at discharge. All right, our next row, GG0170F, is a toilet transfer. This includes the patient getting on and off a toilet or a commode, the use of assistive devices and adaptive equipment like a grab bar or elevated toilet, required to complete the toilet transfer should not affect coding of the activity. If the only help a patient needs to complete the toilet transfer activity is for a helper to retrieve and place the toilet seat riser and remove it after patient use, then you're going to code a number 5, setup or cleanup only. Toileting hygiene and clothing management are not considered part of the toilet transfer activity. If the patient requires assistance from 2 or more helpers to get on and off the commode, then it's automatically a number 1 dependent. So let's do a scenario. The assessing clinician notes that the home health aide visit note, which was documented on the afternoon visit and the start of care date, stated that the aide needed to steady Mrs. Z with light contact when the patient lowers her underwear and then transfers onto the toilet. After voiding, Mrs. Z cleans herself. She then stands up, supporting her own weight as the aide steadies her. Mrs. Z pulls up her underwear as the aide steadies her to ensure that she doesn't lose her balance. How would you code GG0170F1? Toilet transfer start of care performance would be a 4, supervision or touching. The aide provides steadying assistance only as the patient transfers on and off the toilet. Assistance with managing clothing and cleansing is coding under GG130C, toileting hygiene, and is not considered as part of 170F. Let's do another. At start of care, Mrs. S is on bed rest due to a new medical complication. She uses a bedpan for bladder and bowel management. The assessing clinician expects the patient will return to independent use of the bathroom toilet once the current condition resolves. How are we coding GG170F1 and F2? The toilet transfer start of care performance would be coded in 8.8, not attempted due to medical condition or safety concerns. The discharge goal would be coded 06 independent. At start of care, the patient does not transfer on or off the toilet due to being on bed rest because of a new medical condition, but she could perform the activity prior to current medical condition, and it's expected she's going to be independent in the activity at discharge. Next, we get into GG0170G Car Transfer. This includes transferring in and out of the car or van on the passenger side, does not include opening or closing the car door or fastening the seat belt. If the patient's unable to attempt car transfers, for example, there's no car available, or there's weather or other environmental constraints, and their usual status cannot be determined, then you put a number 10, not attempted due to environmental limitations. If at the time of assessment the patient's unable to attempt car transfers and they couldn't perform car transfers prior to this current illness, exacerbation, or injury, that would be a number 9, not applicable. Let's look at some scenarios for car transfer. Mrs. W uses a wheelchair and ambulates for only short distances. At start of care, Mrs. W requires the physical therapist to lift most of her weight to get from a seated position in the wheelchair to a standing position. The therapist provides trunk support when Mrs. W takes several steps during the transfer turn. Mrs. W lowers herself into the car seat with steadying assistance from the therapist. Mrs. W moves her legs into the car as the therapist lifts the weight of her legs from the ground. How would we code GG0170G start of care performance? That would be a 2, substantial maximal assistance. The therapist completed more than half of the effort to transfer Mrs. W into the car by providing significant lifting assistance from the wheelchair, trunk support when taking steps toward the car seat, steadying when lowering into the car seat, and lifting support when moving legs in the car. Mrs. W contributes less than half of the effort to complete the activity. Okay, let's look at another scenario for GG0170G Car Transfer. The day after being admitted to home health, Mrs. N works with an occupational therapist on transfers in and out of the passenger side of a car. When reviewing the therapist evaluation, the assessing clinician reads that when performing car transfers, Mrs. N required verbal reminders for safety and contact guarding assistance from the OT for guidance and direction. The therapist instructed the patient on strategic hand placement while Mrs. N transitioned to sitting in the car seat. Documentation showed that the therapist opened and closed the car door. How would you code GG0170G Car Transfer Start of Care Performance? That would be a 4, supervision or touching assistance. The therapist provides touching assistance only as the patient transfers in the passenger seat of the car. Assistance with opening and closing the door is not considered or included in the definition of this item and is not considered when coding the item. GG0170I is the next item. This is walking 10 feet. This is starting from standing. The activity includes walking at least 10 feet in a room, corridor, or similar space. Use of assistive devices and adaptive equipment, for example, a cane or a leg brace, required to complete the walking activity should not affect coding of the activity. If the only help the patient needs is to complete the activity is for the helper to give them the walker or put it away when they're done, then that would be a 5, setup or cleanup assistance only. So let's look at scoring GG0170I, walking 10 feet. Mr. L had bilateral amputations 3 years ago, and prior to this home health admission, he used a wheelchair and didn't walk. At start of care, Mr. L does not use prosthetic devices and only uses a wheelchair for mobility. Mr. L's care plan includes assisting with fitting and use of a bilateral lower extremity prosthesis. The therapist care plan goal is for Mr. L to walk distances of 30 feet with supervision within his home and then discharge to outpatient therapy. How would you score GG0170I? At start of care, this would be a 9, not applicable. But the discharge goal would be a 4, supervision or touching assistance. The reason for that, when assessing the resident for GG0170I, walk 10 feet, consider the patient's status prior to the current illness, exacerbation, or injury. You would use a 9, not applicable, because Mr. L could not perform the activity of walking at start of care, and he didn't perform that activity prior to the current episode of care. But the therapist expects that he's going to be walking more than 10 feet with supervision by discharge. Let's take this a little bit farther and look at another scenario. We haven't gone over GG0170J yet, but it's the same principle, only now we're walking 50 feet with 2 turns. So at start of care, Mr. B is recovering from a recent stroke and now has difficulty walking. Even with assistance, he's able to walk only 30 feet. Mr. B's care plan includes muscle strengthening and gait training. The therapist expects Mr. B will be able to walk 50 feet with 2 turns safely with the assistance of a caregiver for verbal cues and contact guard for steadying on the turns at discharge. How would you score GG0170J at start of care and at discharge? At start of care, that would be an 8-8, not attempted due to medical condition or safety concerns. The discharge goal would be a number 4, supervision or touching assistance. Mr. B is ambulatory but was not able to walk the entire distance because of his new medical condition, which is the stroke. Since the patient is unable to complete the activity at start of care but was completing the activity prior to this recent stroke, then code 8-8, not attempted due to medical condition or safety concerns, is appropriate. Although not able to complete the activity at start of care, the therapist anticipates Mr. B will be able to walk 50 feet with 2 turns safely with the assistance of a caregiver for verbal cues and contact guard assist at discharge. Next, let's look at GG0170K, walking 150 feet. Starting from standing, this activity includes walking 150 feet in a corridor or similar space. If the patient's environment does not accommodate a walk of 150 feet without turns, but the patient demonstrates the ability to walk with or without assistance 150 feet with turns without jeopardizing the patient's safety, then you're going to code this according to that 6-point scale. The use of assistive devices or adaptive equipment, for example, a rolling walker or quad cane, required to complete the walking activity should not affect coding of the activity. If the only help a patient needs to complete the walking activity is for the helper to retrieve and place the assistive device before or after use, then you'll enter a code number 5, setup or cleanup only. So let's do a practice scenario. Mr. R has recent endurance limitations due to an exacerbation of heart failure and is only walking about 30 feet before he tires, loses strength, and must sit and rest. He reports he was walking 150 feet or more with his cane prior to this exacerbation of his heart failure. How would you code GG0170K? For the start of care or resumption of care, this would be an 8-8, activity not attempted due to medical or safety concerns. The activity was not attempted due to his recent endurance limitations and current medical condition, but he was able to complete the activity prior to the recent exacerbation of this condition. Okay, next we're looking at GG0170L, walking 10 feet on uneven surfaces. This is once standing, the activity including walking 10 feet on uneven or sloping surfaces, either indoor or outdoor, such as turf or gravel. If the patient's not able to attempt walking on uneven surfaces, for example, there is no uneven surfaces available, or there are weather or other environmental constraints that limit access, and the patient's usual status for walking 10 feet on uneven surfaces cannot be determined based on patient or caregiver report, then you would put a number 10, not attempted due to environmental limitations. The use of assistive devices and adaptive equipment, for example, a rolling walker or quad cane, required to complete the walking activity should not affect coding of the activity. Let's do a practice scenario for walking 10 feet on uneven surfaces. Mrs. N has severe joint degenerative disease and is recovering from sepsis. When walking on the uneven driveway was attempted yesterday when Mrs. N came home from the hospital, she reports that her neighbor had to hold her belt and help lift her a little bit during a few steps. The neighbor also provided help to advance the walker across the gravel driveway as the patient walked. How would you score GG0170L at start of care? GG0170L, walking 10 feet on uneven surfaces, would be a 3, partial, moderate assistance. Per patient report, Mrs. N requires help providing some weight-bearing support and assist in advancing the walker as she walked 10 feet on uneven surfaces. The helper does less than half the effort for walking 10 feet on uneven surfaces. The next item for GG170 is M. This is one step or a curb. The activity includes the patient going up and down a curb and or one step. The use of the assistive device required to complete the activity should not affect coding of the activity. So let's look at an example here. Mrs. Z had a stroke and needs to learn how to step up and down one step to enter and exit her home. At start of care, the PT provides needed verbal cueing as Mrs. Z uses the quad cane to aid her balance in stepping up and back down one step. The therapist does not provide any physical assistance. You would code GG170M as 4, supervision or touching assistance. The patient needs only verbal cueing to complete the activity of stepping up and down one step. All right, next we have GG170N. This is 4 steps. This activity includes the patient going up and down 4 steps with or without a rail. The use of assistive devices and adaptive equipment required to complete the activity should not affect the scoring or coding, and if at the time of the assessment the patient is unable to complete the activity due to a physician-prescribed restriction, for example, no stair climbing for 2 weeks, but they could perform this activity prior to current illness, exacerbation, or injury, you would code an 8-8, not attempted due to medical condition or safety concern. Let's look at a practice scenario for GG170M. At start of care, Mr. J has lower body weakness and the physical therapist provides light touching assistance when he ascends 4 steps. While descending 4 steps, the PT faces the patient and descends the stairs, providing minimal trunk support with one hand on the patient's hip and the other holding the gait belt as Mr. J holds the stair railing. How would you answer GG170M at start of care? GG170N 4 steps would be coded 3, partial, moderate assistance. The therapist provides touching assistance as Mr. J ascends 4 steps. The therapist provides minimal trunk support when he descends the 4 steps, providing less than half the effort to complete the activity. The patient requires partial, moderate assistance to go up and down 4 steps. Next, we have GG170O, 12 steps. The activity includes the patient going up and down 12 steps with or without a rail. The use of assistive devices and adaptive equipment required should not affect coding of the activity. And just like in our prior situation, if at the time of the assessment the patient's unable to complete the activity due to a physician-prescribed restriction, then we would code this an 8-8, not attempted due to medical condition or safety concern. So let's look at a scenario for this one. At start of care, Mrs. Y is recovering from a stroke and has 12 stairs with a railing, and she needs to use these stairs to enter and exit her home. The PT uses a gait belt around her trunk and at times is required to support much of the patient's weight as Mrs. Y ascends and then descends 12 stairs. How would you answer GG170O at start of care? GG170O 12 steps would be coded number 2, substantial maximal assistance. The therapist provides more than half of the effort in providing the necessary support for Mrs. Y as she ascends and descends 12 stairs by intermittently supporting much of her weight using a gait belt. Let's do another GG170O 12 steps. Mrs. D is returning home after a hip replacement. She's restricted from stair climbing until she's seen for follow-up MD appointment. Just prior to the surgery, she was able to climb her flight of 12 stairs with standby assistance of her niece. How would you answer GG170O at start of care? That would be an 8-8, not attempted due to medical condition or safety concerns. At start of care, the patient's unable to complete the activity of going up and down 12 steps due to a temporary physician-ordered activity restriction. Prior to the surgery, she was able to complete that activity, so it wouldn't be an NA. That would make it an 8-8. All right, the next one is GG0170P, picking up an object. This activity includes the patient bending or stooping from standing position to pick up a small object like a spoon from the floor. Use of assistive devices and adaptive equipment required, should not affect coding of the activity. If at the time of the assessment the patient's unable to complete the activity, for example, they're unable to stand and could not stand to perform the activity prior to the current illness, then this would be a number 9, not applicable. Let's look at an example. Mr. P has a neurologic condition that's resulted in coordination and balance problems. At start of care, he reports he and his wife worked with the OT and the SNF on picking things up off the floor. He demonstrates how he stoops to pick up a pencil from the floor as his wife provides the right amount of verbal cues for safety and stands by, ready to help in case he loses his balance. How would you answer GG0170P at start of care? GG0170P would be coded in number 4, supervision or touching assistance. A caregiver is needed to provide verbal cues and standby assistance when Mr. P picks up the object due to his coordination issues. Let's look at another example of GG0170P. Mrs. C has recently undergone a hip replacement. At start of care, she walks with the walker without assistance. When she drops a hairbrush from the walker basket, she asks her daughter to locate her long-handled reacher and bring it to her. Using the reacher, Mrs. C is able to bend slightly and safely pick up the hairbrush with the reacher without need of additional assistance or verbal cues. How would you answer GG0170P at start of care? The answer would be coded in number 5, setup or cleanup only. The daughter provides setup assistance only by retrieving the reacher, and then the patient's able to use the device to pick up the hairbrush safely. All right, the next parts of GG0170 are asking about whether or not the patient uses a wheelchair or scooter, and if so, what kind, and can they move around in said wheelchair or scooter. The intent of the wheelchair mobility item is to assess the ability of patients who are learning how to self-mobilize using a wheelchair or patients who used a wheelchair prior to admission. Use clinical judgment to determine if the patient's use of a wheelchair is for self-mobilization due to the patient's medical condition or safety. If the patient is ambulatory and not learning how to mobilize in a wheelchair and only uses the wheelchair for transport within a larger living facility, such as an assisted living or an apartment complex, or for community mobility outside the home, like going to the doctor's appointment or dialysis, then you code 0, no, for does the patient use a wheelchair scooter, and then you skip everything else. All right, so GG0170R, wheel 50 feet with 2 turns, and GG0170RR indicate the type of wheelchair or scooter used. Once seated in the wheelchair or scooter, the activity includes wheeling at least 50 feet and making 2 turns. Indicate whether the wheelchair or scooter used is manual or motorized. The turns are 90-degree turns, and they can be in the same direction, which means 2 90-degree turns to the right or 2 90-degree turns to the left, or they can be in different directions. Maybe they do 1 90-degree turn to the right and then 1 90-degree turn to the left. The 90-degree turn should occur at the patient's activity level. In other words, we're not going to try and jeopardize the patient's safety to find out this information. Let's look at a practice scenario for this GG0170R and GG0170RR. At start of care, Mrs. M is unable to bear any weight on her right leg due to a recent fracture. The nurse observes as the certified nursing assistant in the assisted living facility provides steadying assistance when transferring Mrs. M from the bed into her manual wheelchair. Once in the wheelchair, Mrs. M propels herself safely about 60 feet down the hall using her left leg and safely makes 2 turns without any necessary physical assistance or supervision. How would you score GG0170R and GG0170RR? GG0170R would be coded as a number 6, independent, and of course we would mark manual wheelchair. Mrs. M wheels herself more than 50 feet safely without need for supervision or physical assistance. Assistance provided with the transfer is not considered when scoring wheeling 50 feet with 2 turns. You would score assistance with bed-to-chair transfer in the GG0170E item. For GG0170RR, we would mark that a number 1, manual, because Mrs. M uses a manual wheelchair to self-mobilize. Once seated in the manual wheelchair, Mrs. R wheels about 10 feet, including 1 around the corner to the hallway. Due to shoulder pain, she asks the son to push the wheelchair the other 40 feet around another corner and into the bathroom. How would you score GG0170R and GG0170RR in this scenario? For GG0170R, we would mark number 2, substantial maximal assistance. The helper does more than half the effort to assist them to complete the activity. Remember, the patient only went about 10 feet and the caregiver pushed her the other 40. So that's way more than half the effort, right? And then GG0170RR, the type of wheelchair would be a number 1, manual, because she used a manual wheelchair. All right, let's look at the next items. GG0170S, wheel 150 feet, and GG0170SS, the type of wheelchair or scooter used. Once seated in the wheelchair or scooter, we're looking at whether the patient can wheel at least 150 feet in a corridor or similar space. Again, a lot of patients may not have hallways that long. If you can find a similar space, 150 feet by all means. If it's safe, test the patient accordingly. We are also asked to indicate whether the wheelchair or scooter used is manual or motorized at G170SS. Now, if the patient's environment does not accommodate wheelchair scooter use of 150 feet without turns, but that patient demonstrates the ability to mobilize with or without assistance 150 feet without jeopardizing their safety, go ahead and code them on a 6-point scale. Let's look at an example practice scenario. Mr. N uses a below-the-knee prosthetic limb. Mr. N has peripheral neuropathy and limited vision due to complications of diabetes. Through observation and patient report, the assessing clinician determines that Mr. N's usual performance is that a helper is needed to provide verbal cues for safety due to vision deficits, and the patient mobilizes his manual wheelchair a distance of 150 feet within the home. How would you answer GG0170S and GG0170SS? GG0170S would be a 4, supervision or touching, because Mr. N requires the helper to provide verbal cues for his safety when using a wheelchair for 150 feet. And GG0170SS would be coded in 1, manual, because he uses a manual wheelchair. All right, finally, we're down to our last 2 items. J1800 is any falls since start of care, resumption of care, whichever is most recent. We're going to enter the code either 0 or 1 to indicate if the patient has had any falls since start of care or resumption of care, whichever is the most recent. If they haven't, we don't have to answer how many, which is J1900. If so, we'll go ahead and answer J1900, however. So in order to answer this question, we have to review the home health clinic record, incident reports, and any other relevant clinical documentation. For example, if we have a fall log somewhere. We would also interview the patient and or caregiver about occurrence of falls. And of course, we want to make sure that what we have reported here in this item matches what we have in our incident reports and our documentation. That could be a huge big deal on survey if these don't match, right? One thing that's quite different in the OASIS-D item guidance for this item, J1800, is what the definition of a fall is. This may or may not be what your definition is at the office for your policies and procedures. But for answering the OASIS item, a fall is an unintentional change in position, coming to rest on the ground, floor, or on the next lower surface, such as a bed or a chair. The fall might be witnessed or unwitnessed. It can be reported by the patient or an observer, or identified when a patient's found lying on the floor. Falls are not a result of an overwhelming external force, like a person pushing the patient. They also include an intercepted fall. An intercepted fall occurs when the patient would have fallen if he or she hadn't caught himself or herself, or they hadn't been intercepted by another person. that is still considered a fall. CMS understands, however, that challenging the patient's balance and training him or her to recover from a loss of balance is an intentional therapeutic intervention and does not consider anticipated losses of balance that occur during supervised therapeutic interventions as intercepted falls. So you got to first understand the definition so that we can report falls properly and then answer our J1800 item. Again, you would code a 0 if the patient has not had any falls since the most recent start of care or resumption of care. You would code a 1, yes, if they have fallen since the most recent start or resumption. And a dash is also a valid response but should be a rare occurrence. So let's look at J1800 and do an example here. The discharging RN reviews the clinical record and interviews the patient and caregiver, Mrs. K, and her daughter Susan, determining that a single fall occurred since the most recent start or resumption. The fall is documented on a clinical note from an RN home visit in which Susan reported her mother slipped from the wheelchair to the floor the previous day. How would you answer J1800? That, of course, would be a 1. It also addresses unwitnessed and witnessed falls. Let's look at another. An incident report describes an event in which Mr. S. appeared to slip on a wet spot on the floor during a home health aide bath visit. He lost his balance and bumped into the wall, but he was able to steady himself and remain standing. How would you answer J1800? In this case, it would be still a 1, yes, because an intercepted fall is considered a fall. Let's look at another. A patient is participating in balance training activities during a therapy visit. The therapist is intentionally challenging the patient's balance, anticipating a loss of balance. The patient has a loss of balance to the left due to hemiplegia, and the physical therapist provides minimal assistance to allow the patient to maintain standing. How would you code J1800? Any falls? That would be 0. No. The patient's balance was intentionally being challenged by the PT, so a loss of balance in that case is anticipated. And when that is the case, we don't count that a fall or an intercepted fall. Let's look at one more. The patient's ambulating with a walker with the help of the PT. The patient stumbles and the therapist has to bear some of the patient's weight in order to prevent a fall. How would you answer J1800? This would be a yes. The patient's stumble was not anticipated by the therapist. The therapist intervened to prevent a fall, and an intercepted fall is considered a fall. All right, the last item we have, J1900. This is the number of falls, whichever is most recent, start of care or resumption of care. We're going to answer A, B, and C using 0 for none, 1 for 1, or 2 for 2 or more. So we have to identify the number of falls a patient had since the most recent start or resumption and the fall-related injury here. Again, you're going to review the record, the incident reports, and any fall logs you might have, and then you would also interview the patient and or the caregiver here. We are to determine the number of falls that occurred since the most recent start of care or resumption of care, and then code the level of fall-related injury for each. Now, way back on session 1 and 2, we learned that there are different types of periods of review, different types of episodes. When they're telling you to look since the most recent start of care, resumption of care, they're not telling you to go back to the beginning of this episode. They literally mean to look back to the last start of care or resumption of care date and review records from that point on. That might be more than one 60-day episode. But if they've had a fall in that period of time, you're going to code the falls no matter where they occurred, and then you're going to code each fall only once as far as what kind of injury. And if they have multiple injuries in a single fall, you code the fall for the highest level of injury. Okay? Injury related to a fall. Any documented or reported injury that occurred as a result of or was recognized within a short period of time, like a few hours or few days, after the fall and attributed to the fall. No injury means there was no evidence of any injury noted on assessment, no complaints of pain or injury by the patient, and no change in the patient's behavior is noted after the fall. If all of that applies, that would be no injury. Injury except major includes skin tears, abrasions, lacerations, superficial bruises, hematomas, and sprains, or any fall-related injury that causes the patient to complain of pain. And last, we have major injury. This includes bone fractures, joint dislocations, closed head injuries with altered consciousness, and subdural hematomas, for example. So as you're going through J1900, what we're looking at is, out of all the number of falls that the patient had, how many of each of those falls were either no injury occurred, it was a minor injury, or a major injury. And you're going to answer using none, one, or two or more. At J1900, we're going to do an example here. The discharging RN reviews the clinical record and interviews Mrs. K and her daughter Susan, the patient and the caregiver, determining that a single fall occurred since the most recent start of care resumption of care. The fall is documented on a clinical note from an RN home visit in which Susan reported her mother slipped from the wheelchair to the floor the previous day. Susan contacted EMTs for help returning her to the wheelchair. The EMT assessment at that time identified no injury. Documentation of the RN assessment during the home visit details no injury identified related to the fall. How are you going to score J1900? For J1900A, no injury would be coded 1. B, injury except major would be a 0. And J1900C, major injury would be a 0. Only one fall was noted since the most recent start or resumption, and the patient sustained no injury in that fall. Let's do another. Review of the clinical record and incident reports and patient and caregiver report identify that a single fall occurred since the most recent start or resumption. The fall is documented on a clinical note from an RN home visit that describes the patient Mr. R's report of a fall that occurred between visits in which he tripped on the dog, fell against the wall and banged his elbow, sustaining a skin tear that he treated himself. Documentation of the RN assessment during the home visit details the healing skin tear and no other injury or symptom identified related to the fall. How would you code J1900? A would be 0, B would be 1, and C would be 0, because he had one fall since the most recent start or resumption, and a laceration is considered an injury except major. All right, let's look at another. Review of the patient record and incident reports and patient and caregiver report identify that a single fall occurred since the most recent start resumption. The fall is documented on an incident report that describes a telephone call from the patient, Mrs. B's daughters, Mary, in which Mary reported Mrs. B fell at home and hit her head and was transported via ambulance to the emergency room. Examination and testing revealed a subdural hematoma. Mrs. B was held in observation stay and received treatment, returning home in stable condition after 48 hours. How would you code J1900? 1900A would be 0, no injury, because she didn't have any no injury falls. 1900B, injury except major, would also be a 0, but J1900C is where we're going to capture that fall because she had a subdural hematoma, and that's considered a major injury. Okay, let's do one more. In this particular event, we review the records and do our interview and find that Mr. G tripped on the bathroom rug and almost fell, but caught himself against the sink. The RN assessment identified no injury. The second describes an event during which Mr. G, while coming up the basement stairs with the laundry, fell against the stairs and sustained a bruise and a laceration on the left knee. So in this case, we have two falls. How would you code J1900 in this case? A, no injury would be 1, and B, injury except major would be coded 1, and then C, major injury would be 0. The first fall was an intercepted fall, which is still considered a fall, but the patient had no injury as a result. The second fall resulted in laceration and bruising, which is considered an injury but not a major injury. Okay, let's do one more. In this case, we reviewed the patient record and the incident reports, and we did our interview and found out that the patient had a single fall since the most recent start resumption. The fall is documented on an incident report which describes an event during which Mrs. J fell while walking from her bedroom to the bathroom and was transported to the emergency room via ambulance. Examination and testing revealed a skin tear on Mrs. J's left hand, bruising on both knees, and a fractured left hip. Remember, when you've got multiple injuries, we default to what? The worst injury. So how are we answering J1900 here? For A, no injury, that would be a 0. B, injury except major would be a 0. And C, major injury would be a 1. Documentation of only one fall since the most recent start or resumption was identified. The patient had multiple injuries, and when that happens, you code the injury of highest severity. All right, one last scenario. The aide who visited the patient on Monday discovered the patient had been hospitalized for 2 days and discharged home on Sunday. And by the way, this is more along the lines of the one clinician rule and doing our discharge. So just bear with me. We're going to do a general scenario here. The RN visits the patient on Tuesday to do the resumption of care assessment, and the PT visits on Wednesday, and then the OT visits the patient on Thursday. Based on the expanded collaboration allowed effective January 2018, could the nurse use information from the aide and the PT and OT visits to complete resumption of care OASIS items? A side note, this is not one of my made-up scenarios. This is a CMS scenario, and when we do this one in class, it often comes up, someone asks, we don't have any orders. Because of the answer that CMS gave us, we are to infer, in this case, that we did have orders. We didn't know the patient was in the hospital. The aide went back out on her regular visit and noted that the patient had been out to the hospital for 2 days and came home Sunday. And so I would assume in this case the case manager at the office called the hospital and told them we didn't get orders, and they faxed the orders over. So the question now becomes, when the RN visits the patient on Tuesday to do the resumption of care, can the RN consider the PT visit on Wednesday and Thursday's OT visit based on expanded collaboration? And the answer is, at resumption of care, the assessing clinician may supplement his or her assessment with information conducted from other agency staff visits within the assessment time frame. A resumption of care assessment must be completed within 2 calendar days of facility discharge or knowledge of the patient's return home, or effective 1/13/18 on the physician's ordered resumption of care date. In this scenario, the resumption of care date is Monday, because that's the date of the first billable visit following a qualifying inpatient stay, and the assessment must be completed by Wednesday. That's 2 calendar days of agency knowledge of the patient's return home. If desired, the nurse may use the information from the 3 visits that occur within the assessment time frame. Again, that's the home health aide visit on Monday, the RN assessment on Tuesday, and the PT visit on Wednesday. And they can use that information to complete the resumption of care assessment. The OT visit on Thursday is outside the assessment time frame, and information from that visit may not be considered when determining OASIS responses. Well, this concludes our OASIS-D Accuracy webinar series. I want to thank you for attending. I hope you learned something that's going to be useful to you. In the meantime, if you have questions or you require further clarification, feel free to contact me. Jennifer Gibson Osborne here at Axxess. You can reach me on my email, jgibson@axxess.com, or you can call and leave a voicemail or text message to my cell phone, which is 972-975-0417. And as I always say in my conclusions of my series, I want to take a moment and thank you for what you do. I don't care what your title is in home health or what your job is. It's an important job that you do, because we know if you weren't there every day doing the work that you do, some patient who deserves the care in their home that they're receiving would not get that care, or they wouldn't get the quality of care that they're receiving because of you. So if nobody else thanks you and you feel like you have a thankless job, just know that Axxess and myself, Jennifer Gibson Osborne, we do appreciate what you do to take care of these patients. So thank you again. We hope you have a wonderful day, and we appreciate you using our references in our library of content to help you learn more about what we do in home health. Have a wonderful, blessed day. Thank you.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.